down
I
forward. So
figured as much, but I was like.
for flexion, y'all have seen flexion before. Y'all measured each other's flexion before. Do you remember that?
I was like,
Intro to Goni?
I don't even remember.
like the third week in.
Are you
We
sure
could
you
go
did
here.
it?
I'm like, I
What?
I wasn't here the third weekend.
At least not mentally.
Okay.
Okay, so have your scoop as close as you possibly can. There we go. Okay, perfect. Okay, so for flexion, we know the motion, right? So all I want you to do, I'm going to take her through active and passive and all that fun stuff. All I want you to do is bring your arm up as high as you can. Beautiful. Then bring it back down. Now I'm going to take her passively. You remember the little trick for passively taking somebody through? Twist their arm. I switch my hands, right?
Oh, yeah.
That little trick. Yeah. And then I can get my infeel, which is table.
Is that the clinical name?
That's, we didn't talk about that abnormal infeel, but you could also get one called table. So I know that she's got normal range of motion, right? So last lab, somebody brought up or asked the question, well, if we know that they're going to get 180 degrees, can we just line up everything once they get into that point? Sure, when you're in the clinic. Right? But not here. So until you get to that point, we're going to start with specific points here, but if she gets to 180, our points are going to change. Remember that? Yeah. So in this position, what do we want to line up our fulcrum with?
Head of the humerus.
Okay, head of the humerus, but that's like deep in the
Greater
socket, so it's
tubercle.
hard to find.
Oh, great.
Greater tubercle, right? So we can use our acromion to find the greater tubercle, right? Remember that little trick? Take these two fingers, put it on either side of the acromion, and then take this little guy, and I'm going to stick him down in between till about my proximal interphalangeal joint, right there, and then I should be on her greater tubercle right there. She didn't like that for some reason.
No.
But that's where it is. It really had sense.
It's just it's like when somebody like goes like that to your greater trochanter, you're like, ah, that hurt.
I didn't know that.
She's okay now. Okay, so there's her greater tubercle, and it's tubercle, not tubercle.
Tubercle.
Tubercle. Okay, so that's going to be my fulcrum. I've got two arms here, proximal arm. Where do you think that's lined up with?
The body.
Body, okay. Torso, we can say that it's parallel to the plinth, at least for the most part, unless we start to get some compensation, right? And then my distal arm is going to be lined up with the shaft of the humerus. Specifically, we can use lateral epicondyle as a nice bony landmark. Okay, so that's our starting, excuse me, edit that. That's our starting point for flexion. Okay, now I know that she's got well over 180 degrees, so I'm not going to have, but, oh crap, I got to stay in line with my, still in line with all my points. Right?
You're not in line
Oh.
with torso.
There we go. Still in line with all my points.
There you go.
But what just happened?
Got squishy.
It just rotated. They got squished because everything rotated and disappeared on me, right? So if we know that they can get past 90, 100 degrees, somewhere around there, 90, 100, between 90 and 100 degrees, then we start to actually go into quite a bit of external. Thank you. Okay. We get some rotation going on there, and because of that rotation, it makes our points disappear. But we have other points, right? The armpit. Okay. So now we can go back to humeral head,
Wait.
because now we can see the humeral head better than we can the greater tubercle, right? Humeral head. There it is. Okay? When we go into full flexion, it actually anteriorly translates that humeral head to our advantage. So now we can use it. So I line up my fulcrum, and I don't have to like smash it up against her, okay? I can let it float here, and that floating comes into play when we talk about abduction as well. But I can let it float out here. I line up with her trunk. I'm not going to line up with her lateral epicondyle, or, yeah, that's right. Lateral epicondyle. I was thinking I thought I said malleolus first. But now I'm going to line up with her olecranon process instead. Again, because of the fact that we've had that rotation that's occurred. If I were to line up with her epicondyle, it's not going to be a straight line or in line with her humerus anymore, right? And I want to try and line up with the point that keeps me in line with the shaft of the humerus. So I'm going to be in line with that olecranon process. Okay? If I do that, she's a little bit above 180 degrees, but not much. She's at 185 degrees. What's normal? 180 degrees. Good. Okay? So, again, our points change. We know that if they go past that 90 to 100 degrees of flexion, we're going to have to find those new points or line them up with something else. But if we're starting here and she only gets to there, I can still stay lined up with her greater tubercle and that lateral epicondyle. Okay? Any questions on flexion? Yes?
Are we differentiating between the GH and the complex? Or is it just...
No. Yep. This is just, we're not, hopefully our scapulohumeral rhythm is working appropriately, and that's going to allow us to get full range, right? If it doesn't, then yeah, we want to start looking at that. Okay, how's that scapula moving, as well as what's going on with the glenohumeral capsule itself. So.
And then as you palpate, or how did you locate the humeral head?
Oh, when she was at 180 degrees?
Yeah.
It's essentially right there. Everybody's body, as they go into full flexion, that humeral head will rotate and then anteriorly translate enough that it will actually cause, that's what that little bump is.
So you can actually see it then?
Yeah, right there.
Hey Jake, what's up?
I don't see it.
Well, I mean, she's got skin and stuff anyway. But if I were to palpate, I can feel that, and if I even push enough, now, yeah, it's not going to be the most comfortable, but, and it's ticklish, right? But I can feel that humeral head doing an anterior posterior translation.
Can I push on your humeral head?
So, yeah, if your patient will let you, go for it. Okay? So, that's flexion. Good question.
So when you're taking them through the motions, will you kind of be able to tell if you need to like measure up until 90 degrees and then past it here, or would you always do both anyway? Do you understand?
Sure. So that's the purpose of having them actively perform the motion and then us passively, right?
Right.
So if she actively goes through and she can go to right there, and then I passively, and I bring her to that point as well, there's my abnormal end feel. I know that I'm not going to have to worry about the other
Switching it
point,
over,
switching
right.
it over.
It's mainly like the opposite though. So like, do I have to like measure some? I think mainly thinking about like practical, I guess.
Ah.
So like, would I have to measure up until here, even though I already know she can go to here? Or would I just take her into this motion and then measure?
Oh, well, you're going to line up, right? But it's not like you're going to get to this point, take your measurement, say 90 degrees, and then stop, and then continue on to get your full. You can just keep it all lined up there and have her go through or take her through that motion. But now, again, I'm falling off. I can just make my correction, get back lined up, And now I'm getting my
So as you go through, you just kind of adjust as
Mhm.
the humeral head rotates.
Again, when it comes to clinic, or like when you're in the clinical and stuff like that, we're not we're not like telling your CIs, oh, when they do goniometry, they have to start here and go through the whole thing. We're not telling them that. The biggest thing is that while you're in here, it's just to help you guys know where your zero's at and what numbers you're looking at as you go through the motion or when you take the actual reading.
Okay.
Okay, good question. Emily, did you have a question back there as well?
Well, yeah, because you told us about like the little hand switch over when you go through, but I feel like there's not enough hands to do that and measure.
That's only when I'm taking them passively through to find my end range.
Okay.
When I'm doing the actual motion, for like taking the actual measurement and stuff, I'm not gonna do that. I'm gonna be here, and I'm gonna follow her along as I
Okay.
take the measurement. So I'm not worried about like, yeah, I don't have 3 or 4 hands either.
Okay.
But, so really, that only applies if we're just passively taking them through that, doing a range of motion exercise. Yeah.
Did you already say what the end field would be?
I did not. So what would the end field be? What would normal end field be?
Soft tissue stretch.
Soft tissue stretch, firm. Okay. Good. Let's move on to extension or hyperextension.